Record. Welcome everyone to this session in our Research Grant Symposium. We are showcasing our faculty members who were awarded our faculty research grants in 2022. I am very happy to turn the floor over to Dr. Vicky Graham, and please feel free to ask questions about the presentation as we go. And I'll turn it over to Dr. Graham.
All right, thank you, Dr. Douglas. I'm happy to be here. Thank you all for joining us this afternoon and listening to a little bit about this research study that I was involved in. I'll let you read the lengthy title here, but I do want to acknowledge that I can't do this alone. And I'm really fortunate to work with a great research team at Cincinnati Children's Hospital. And, you know, it does take a village, but we all work together, and I'm really happy to work with this great group of people. A few disclosures. This study was funded by a 2022 faculty research grant, and we're all very appreciative of the support of the university and the graduate school of this research line. Our grant before that, we have a paper in review right now, and have another ongoing study funded. So we're really happy and grateful to APUS. The study was approved by the IRBs at both institutions, and none of us has any conflicts to disclose. For those of you who maybe aren't familiar with athletic trainers and what athletic trainers do, ATs are healthcare providers that are trained in prevention and care of medical conditions, including emergent, acute, and chronic injuries. One of the settings that ATs work in is in the secondary schools. And, you know, research has shown that schools with ATs have lower rates of musculoskeletal injuries, lower rates of re-injury, improved recognition and management of concussion, among a number of other things. So there are a lot of benefits to athletic trainers being on site at the schools. And one of the roles the athletic trainer does play and is able to play in the secondary school is that they can provide rehab services at the school. So if someone sprains their ankle and is injured, they can also do the rehabilitation after school with that athletic trainer. And this helps to improve access to healthcare. And in the group that we're studying, which is in an urban area where a lot of students are on publicly funded health insurance, and a lot of students and their parents take public transportation to school or work respectively. It's really difficult for people to seek care, or for a parent, you know, a parent can't just jump in the car and come to school and pick the child up and go to a therapy appointment. You know, it's not really necessarily possible at all, and that leaves a big gap in care for students a lot of times. So the AT can help provide improved access to care. The rehab after school is a big piece of that. It's certainly more convenient. It reduces school absences, and it overall improves the overall continuity of care as well for the athlete, for the injured student athlete. We identified a knowledge gap. We understand that, to our knowledge, there's no published research about patient-reported outcomes that are associated with rehab that's been led by ATs, provided by ATs. And we also noted that there aren't any studies on whether the amount of time that the AT spent during the rehab process with the student athletes makes a difference in their recovery, as far as not minutes per day necessarily, but the amount of visits that the student athletes are able to have over time. So the purpose of this study was to examine the effectiveness of rehab services provided by ATs for student athletes with ankle sprains and patellofemoral injuries, as measured by patient-reported outcomes and time to unrestricted physical activity. I know that's a little bit to unpack, so we'll unpack it. We chose ankle sprains and patellofemoral injuries because they're two of the most common injuries that athletic trainers see, especially in that age group. I'm going to talk about patient reported outcomes and what they are in a moment. And unrestricted physical activity means that the patients return both to normal activities of daily living, so they can walk, they can walk up and down stairs, they can get in and out of a car, in and out of the shower, they can care for themselves, and so on, get dressed, all those types of things. And they don't have any restrictions back to their previous level of function in their particular sport. So let's talk about patient-reported outcomes. What are they? Really, all they are is I always describe it to patients as a snapshot of their own perception of their health at a particular point in time. It's truly a picture. If you take a picture, that moment's gone, right? But you've captured it. That's all we're doing with the patient-reported outcome. The key point is that this information is directly reported by the patient. It's not reported to a provider or a clinician, and then the clinician interprets it. It's coming directly from the patient. And this is really, part of the basis of patient-centered care. So a patient-reported outcome measure is just simply the tool or the instrument that is used to measure that patient-reported outcome. And typically, these are just standardized, they're surveys. They're research-validated surveys. And if you've been to your primary care physician, in the last year, you may have been handed a little brief survey about some aspect of mental health. There's been a big focus in primary care in helping to identify people who are at risk for self-harm primarily. But, I know I got about a 5-question survey on issues related to depression, anxiety, and whether I had thoughts or intent to harm myself. So it just is, one example of a patient-reported outcome measure that you might be familiar with. So for our study, this is a prospective study of lower extremity injury care by ATs. Our participants were secondary school athletes who had sustained either an ankle injury or reported patellofemoral pain to the athletic trainer. And they were recruited by the athletic trainer, athletic trainer at the school, at the time that they sought care. Now, the athletic trainer certainly provided care and evaluated them and treated them and did everything that they would normally do, but they also at that time would have discussed the study with them and to gauge interest. And then if the athlete were interested, then the recruitment materials would be provided and so on. We did require parental consent and student assent. So when the student indicated interest, then again, they were provided information, both written and verbal, and then that information was sent home with them. We provided a small incentive of a $20 gift card for completion of the study, primarily so that we could try to capture that parental consent and have that piece of paper actually come back to us, to the athletic trainer at school. And then the student really only had to do was follow the AT instructed rehab program, which they would be doing anyway, until they were back to their baseline level of function, and then complete the patient-reported outcome measures. And we tracked the rehab progress over 4 time points. So they completed that patient-reported outcome measure 4 times. The date of the enrollment, ideally that would be the date of injury, but because we had to obtain consent, unless the parent happened to pick that child up at school on a given day, it typically was a different date. And then we captured it 7 days from the date of injury, 30 days from the date of injury, and then the date they returned to unrestricted physical activity and in their sport. And just to note that date of return could be before or after 30 days. Someone could come back in 8 days or 3 days or 29 days. So that date might vary. They could come back in 35 days. So the two measures that we chose to use, we used the FAM, or the foot and ankle ability measure, for the ankle injuries, and the IKDC for knee injuries. And these are both well established and validated outcomes measures. I'm going to just talk about the FAM and about the ankle today. There are 2 subscales within that, and I'll show you a couple of examples in a minute. But there's an activities of daily living subscale, and then a shorter sports subscale. the shorter survey is part of the FAM. The response options are on a 5-point Likert scale. They range from 4 to 0. 4 is a higher level of function. 0 is the lower level of function. And, it's nice because the subscale scores go up to 100%. So you kind of have an easy way to understand what that means if somebody scores 53%, like they're going to in an example I show you in a minute. So here's an example of a question. This is from the activities of daily living subscale. Do you have difficulty standing? If this were to be scored, or for the patient answering this, they're going to choose, I don't have any difficulty standing. They choose none at all. That's 4. They get 4 points. If they were unable to do that, they would get 0 points, and you can see what they would get in between. And these are the possible answers for every single question on both subscales. So here's just a sample report that I ran. You can see some of the questions, and you can see here at the top, difficulty with running, with jumping, landing, stopping and starting quickly. This person has slight difficulty, so they got 3 points for each of those. They have moderate difficulty cutting with lateral movements. That's 2 points in scoring. Extreme difficulty performing activity with normal technique. That's 1 point. And then they're unable to participate in their sport as long as they want to. They're unable to do that, so that's 0 points. So all of those scores are summed. And for this sample report, this person got 17 out of 32 possible points on the subscale. So their score is 53%. So it's scored fairly simply. And they do have this so that you can administer these online, and it's pretty quick for the patient to fill out, and it scores it automatically for you. So now this is the data from our actual, from our study, and I can't quite see it because of all the Zoom stuff on my screen. But we've got, again, the activities to daily living schedule and percentage of positive responses. This is basically that sum, that percentage. So that last slide that I showed you where the person scored 53%, that's what this is. This is showing you that percentage for this. This is the mean of all our participants, starting with the date enrolled, going to 7 days from the date of injury, 30 days from the date of injury, and the date of unrestricted activity. And again, remember, this could actually in real life occur before or after. And there was a significant difference among all these time points when compared to the date enrolled. You see the upward trend of people improving and getting closer and closer to 100%. And this is what we expected to see. Here's the sports subscale. Similarly, again, it's the same thing, percentage. So our 53% would have landed over here for this person. This is, again, date of enrollment, 7 days, 30 days, date of unrestricted return. And again, we saw significant differences between each of the time points, again, which we expected. We expect that people are going to improve with rehab. We want to see how quickly they improve, if that is different than previous studies of other providers, if the amount of time that they spend with the provider over time makes a difference or not. I mean, there are a lot of things that we want to look at, but this is just a snapshot of our FAM data. So here's what we found and where we're kind of at with this. We saw the positive trends, as I just said. Prior to the study, our a priori power analysis, we thought, our statistician said, we need a minimum of 30 participants for each injury type to be able to have usable data. And we knew we would have barriers, particularly with getting consent, which is why we offered the incentive. And we still need additional participants. We got about half of our participants for the ankle and a little less than that for the knee. And with more participants, we'll also be able to examine the time spent as another factor. So what we've done is, well, let me talk about barriers first. Barriers that we really experienced, as I said, parental consent was an issue, and it wasn't that parents didn't want to consent. It was a matter of the written information went home, high school students explaining this to a parent. Even though there's contact information for people that you can contact about the study. We never received one phone call. There was an email on there, not one email. No one called the athletic trainer at school back. So, you know, a lot of times it's just a student might say, yeah, I want to do this, and it goes home, or maybe it never makes it home, or they forget. They forgot a lot. So this became just a huge barrier. We were told by some other people at the institution, but also by these students, well, $20 isn't anything. It's just not enough to be a good incentive. And our thinking at the beginning was, you know, we really only want you to fill a survey out 4 times. But it, you know, and I don't know if the incentive would make a difference or not, because I think the issues with parental consent are still there. Another big factor that occurred is that we had the schools that are serviced by the outreach program at the hospital, the school districts changed from the end of one school year in the spring to the beginning of the fall school year. So mid-year, we had athletic trainers all go to new schools. So they spent the fall, you know, learning the ropes at the new school, building relationships with coaches, with administration, with student athletes, with parents, and so on. And, you know, it's just very difficult to try to recruit people while all of that was going on. And we also had a few ATs either go on maternity or paternity leaves. And while they were out, the people subbing in for them at the schools were not recruiting people into the study. So we had a perfect storm of some known barriers and some unexpected occurrences as well. So our plan, we have some data, but we don't have enough participants. Our plan is to continue the study. The hospital's given us a no-cost extension. So we're not going to offer the incentives, but we're going to be able to continue the study beyond this year. We have a current study on acute ankle injury care that's aimed at reducing emergency department use for the injury. And as part of that study, the athletic trainer it will be phoning home to speak to the parent or guardian about care for this ankle injury. So we're hopeful that that'll help to build some relationships, and that we're also going to be able, at least for the ankle injuries, to also recruit some of those people into this study, because they're already going to be talking to the parents. So we think that we may be able to, you know, again, recruit some of them. So that's kind of where we are right now. Does anybody have questions?
Please feel free to come off mute, or if you'd like to type in the chat.
Hey, Vicky, it's Karen. Nice job.
Hey, Karen. Thank you.
I was just wondering about the students and how they feel about participating in a study. Like, do they think it's cool to do some of these things? And could that help with recruiting overall, like as you continue to try to find more people?
Well, I mean, I think that over time that probably occurs. I don't, you know, I think it's just got to snowball at some point. And at some places, kids might think it's cool to do a study. You know, you know, the biggest issue with this one is just the parental consent piece, because, you know, and again, it's not that the parents don't want to consent; it's that it's paper based. You know, we were able to enroll a few people that picked their kids up or came to school for some purpose, and we were able to recruit some people that were seen, that were maybe seen by the AT initially and referred to sports medicine clinic, and then we were able to capture them at sports medicine clinic because the parent brought the kid to the doctor. So it's just kind of dealing with high school kids and their sense of responsibility and what else is going on in the world. And is that paper, you know, at the bottom of the backpack, or is it with all their homework and they actually do their homework? You know, it's sort of a, you know, crapshoot, for lack of a better term.
Yeah, well, it is. I think it's hard getting participants in any study almost. So.
And it's, you know, kids say, yeah, I'll do that, you know, and $20, they'll take $20. It might not be a lot to them, but it's still $20 and they'll do it. But again, it's, you know, how motivated are you? And then we had a few that, you know, went through part of the study, and then, you know, they felt like they got good enough and they went back to their sport, and they didn't come back for day 30 or So we had a few that we lost that way.
You're focusing here on care by the athletic trainer, correct? So in doing that, what are some of the things you might hope as outcomes in terms of athletic trainers within schools or relationships with athletic trainers? Is there sort of an application direction that you're thinking of with this?
Oh, I think it's helpful to be able to demonstrate that the outcomes are similar to doing it's still outpatient rehab. It's similar to doing outpatient therapy with another provider, whether they're going over to the hospital and doing PT at the hospital or through a private clinic, but there's similar outcomes, and there are benefits to doing it at school, and there's no copay there, number one, and number two, and because you're not dealing with insurance from that standpoint, you're not limited in the visits that you can go to. So depending on the kind of insurance, that there are significant limits to how many times you can see someone, and those are barriers for people seeking care. So if you can be seen every day after school, and you're not tapping into your insurance, and you're not taxing the formal healthcare system at the hospital or elsewhere, then that's beneficial in allowing people to be able to get, people who really need it and have no other choice, to be able to get in. And it's also just kind of demonstrates another way of demonstrating the value of having care provided at school.
Thank you. Do we have any other questions for Vicky? Sounds like you have a really interesting line of research going here with the series of studies that you've been working on.
Excited about it. We're a little disappointed that this one didn't fly as well, but we're happy that we were able to extend it. So we'll see what happens. I know it's not as exciting as going to Ireland, but kind of rethinking my line here.
I'm sure they have ankle injuries in Ireland too.
I know. I'm thinking that maybe I should talk to Jackie and we can collaborate on something over there.
Well, thank you. I'll do a little bit of housekeeping